Mary, let's just wait 1 more minute, okay? I sent you a message.
Good morning. I'm Dr. Mary Stephen. Welcome to the WHO Africa Media Briefing. First, some housekeeping. We have interpretation in French and English. Please go to the bottom right-hand corner of your screen, click the globe icon and select your most preferred language. Vincent, can you explain in French, please?
Bonjour et bienvenue à la conférence de presse de l'OMS Afrique. Pour choisir la langue dans laquelle vous voulez suivre cette conférence, vous pouvez cliquer sur le globe en bas à droite de votre écran et choisir la langue dans laquelle vous voulez suivre la conférence. Merci beaucoup. Bonne conférence.
Merci, Vincent. And now joining us from Brazzaville, Congo here is Dr. Matshidiso Moeti, the WHO Regional Director for Africa. And Dr. Moeti will now introduce our other panelists. Over to you, Dr. Moeti, and welcome.
Good morning, good afternoon, bonjour, and welcome to all the journalists joining this press conference today, where we'll turn the spotlight on the heavy toll that the COVID-19 pandemic continues to take on women and on their health. I'm very pleased to be joined for this conversation by a leading woman scientist and researcher, Professor Francine Ntumi, founder and president of the Congolese Foundation for Medical Research. Bonjour et bienvenue, Professor Ntumi. And also by Dr. Elena Nwadinobi, the president of the Medical Women's International Association. A very warm welcome indeed to this important press conference ahead of International Women's Day next Tuesday. There have now been more than 11 million COVID-19 cases and almost 250,000 lives sadly lost in Africa due to the pandemic. We can report, however, that overall case numbers continue to trend downwards in most African countries following the fourth wave peak. Yet for women in Africa, the pandemic's disruptive force will be felt for many years to come. 2 years on, interruptions to essential health services as a result of pandemic response efforts are still being broadly felt. New WHO analysis shows that as many as 40% of African countries are reporting continued disruptions to sexual, reproductive, maternal, newborn, child, and adolescent health services. The consequences of this for women's health are a serious cause for concern. One survey of 11 countries in Africa revealed that more than half saw a 16% increase in maternal deaths between February and May 2020 compared to the same period in 2019. That statistic decreased slightly last year to 11%, but the actual number could be much higher because home births are excluded from this data. And every additional death of a woman giving birth to a child is an unacceptable outrage. Teenage pregnancies and incidents of violence against women are also increasing exponentially, with the situation exacerbated by pandemic-related school closures. In Kenya, according to a new paper in the British Medical Journal, adolescent girls who couldn't attend school for 6 months were at twice the risk of falling pregnant and 3 times more likely never to return to class. Global statistics reveal that 1 in 4 women are experiencing more frequent conflict in their homes. As many as 45%, that means almost half of women, have also reported that they or someone that they know has been subjected to gender-based violence since the onset of COVID-19. The gravity and extent of these consequences cannot be overemphasized. Interruptions to health services are exacerbating women's often already limited access to healthcare, especially in the African region. And short-term measures to restore services to pre-pandemic levels are not enough. Meanwhile, COVID-19 is also inflicting extensive economic damage, with the pandemic pushing more women and girls into extreme poverty. Predictions are that it would take almost another decade before spiraling poverty rates are restored to pre-pandemic levels. According to UN Women, 247 million women and girls aged 15 and older were living on less than $1.90 a day last year due to the economic impacts wrought by COVID-19. More than half, that is 54% of them, were in sub-Saharan Africa. And that's a disproportionately high number, considering that the whole of Africa constitutes just 16% of the world's population. Existing gender inequities have deepened significantly too. For example, women constitute 70% of the health and social workforce and are at the forefront of the pandemic response. Yet in the African region, 85% of national COVID-19 task forces are led by men. As WHO in Africa, we urge African countries, donors, and partners to dig deep to make the kinds of investments necessary to strengthen health systems. To protect women's access now into the future, these systems need to be capable of withstanding future shocks while maintaining delivery of primary health care. And gender inequity as a determinant needs to be woven into the design and delivery of interventions to improve health. Investing in women's economic participation, livelihoods, and health is an investment in the health of future generations of Africans. Our continent cannot afford any further reversals of the fragile gains made in pursuit of equitable care for women and girls. Another challenge looming for the continent is the urgent need to address obesity. And I mention this because tomorrow we will mark World Obesity Day with a new WHO analysis revealing projections that cause great concern. By the end of next year, 1 in 5 adults and 1 in 10 children and teenagers in 10 African high-burden countries are likely to be obese if robust prevention measures are not taken. WHO recommends a range of priority interventions, including government regulations such as mandatory limits on energy-dense foods that are high in fats and sugar, taxing sugar-sweetened beverages, as well as promoting healthier foods for older infants and young children. For consumers, it's important to distinguish between safe oils and fats that threaten health. Good fats come mainly from vegetables, nuts, seeds, and fish. Saturated and trans fatty acids that can raise cholesterol levels, clog arteries, and increase the risk of heart disease are found in fatty meats, in fried foods, baked goods, and processed snacks. This is a ticking time bomb, complicated by Africa's double burden of growing obesity and severe malnutrition. Both of them need to be addressed at the same time through universal access to effective nutrition, which in turn requires sustainable and resilient food systems. So while COVID-19 continues to demand much of our attention, we must strengthen the response to Africa's many other pressing health issues while prioritizing women's empowerment, engagement, and health. I look forward very much to our discussions today, and thank you again for having joined us.
Thank you very much, Dr. Moeti. And now, Dr. Francine, can you please give us some perspective on how COVID-19 has affected women's health?
Thank you very much. Madame la directrice régionale de l'OMS, Dr. Moeti, Dr. Noadinobi, et bonjour à tous. Je remercie donc les organisateurs pour l'invitation à participer à cette conférence de presse et à partager avec vous mon commentaire. Alors, lorsqu'on parle de la recherche médicale et de la pandémie à la COVID-19 et la santé des femmes, je pense tout d'abord à un point positif pour pas rentrer tout de suite dans les choses négatives. Le premier point positif, c'est que alors que les hommes et les femmes ont la même prévalence suivant les pays de l'infection, les hommes atteints de COVID-19 sont plus à risque de pires résultats et de décès, quel que soit leur âge. Ici, au Congo-Brazzaville, 40% de femmes ont fait l'infection et le taux de létalité est plus faible chez les femmes avec 1,3 versus 1,7 chez les hommes. Bien sûr, les mécanismes responsables de la réduction du taux de létalité chez les femmes ne sont pas actuellement clairs, mais pourraient offrir un potentiel pour développer de nouveaux outils et offrir donc de nouveaux outils de stratification des risques et des options thérapeutiques pour les femmes et les hommes. Le deuxième point auquel je pense par contre est négatif. La mortalité maternelle au cours de la grossesse est encore très élevée, comme l'a mentionné Dr. Moeti. La plupart des interventions planifiées ou les essais cliniques sur des outils utilisés, traitements, vaccins, excluent généralement les femmes enceintes. Ce qui fait que les femmes enceintes bénéficient que tardivement de l'avancée des progrès donc, de la science, et c'est le cas pour le vaccin qui est un outil qui a montré son efficacité dans les cas graves et dans les cas de décès. Et donc, nous appelons vraiment à une action urgente pour assurer son accès privilégié à la vaccination pour les femmes enceintes. Le troisième point, alors là, ce n'est pas mon champ d'expertise, mais il y a un besoin d'études sur la santé mentale. On oublie souvent la santé mentale des femmes au cours de ces confinements que nous avons eus en 2020 et lors des vagues successives. Et quand on regarde donc de la structure de nos familles où la femme est au centre, dans la gestion des malades, avec un grand risque d'exposition, la gestion de la famille avec les revenus qui ont baissé avec le confinement et la perte de beaucoup de revenus, des cas de dépression ont été observés chez les femmes, mais cela est très peu étudié. En tant que scientifique, donc, je note qu'il existe trop peu d'études sur la femme enceinte ou non enceinte sur la COVID, mais la plupart des études sont des études qui ont été menées en Europe ou en Chine. Et donc, cela m'interpelle. Il faudrait vraiment un plus grand nombre d'études soient conduites avec la femme africaine au cœur de l'investigation, en regardant l'hypertension, l'obésité, le diabète, pour comprendre comment toute la pandémie et ses comorbidités affectent spécifiquement la femme. Voilà, merci de votre attention et je me réjouis de la discussion.
Merci beaucoup, Dr. Ntumi. And now to you, Dr. Wadinobi. Please, could you tell us about the link you're seeing between COVID-19 and violence towards women?
Thanks very much indeed, first of all, for inviting me and hearing from Dr. Moeti and Dr. Ntumi. When we realized that the pre-pandemic estimates from WHO indicate that globally 1 in 3 women and girls had been subjected to one form of violence or the other, including sexual, intimate partner violence and non-partner violence. And then we had COVID-19 making landfall. It then meant that the violence that we saw regarding women and girls, which was already of pandemic proportions, was now exacerbated during the COVID-19 pandemic. So much so that we at the Every Woman Treaty, advocating for a treaty to end violence, called it a pandemic within a pandemic. UN Women called it the shadow pandemic. Some called it the silent or intersecting pandemic. Because what happened on account of lockdown? We had, in a single day, UK's largest charity, Refuge, reporting 700% increase in calls to its helpline. In the 21-day national lockdown, initially, South Africa reported 87,000 incidents of gender-based violence. In Nigeria, our Inspector General disclosed that between January and May 2020, there were 717 rape cases. I recall with sadness the case of Uwa in Edo State in Nigeria, where I live, a 22-year-old girl who went to the church to study during the lockdown. And she was beaten, raped, and hit and killed with a fire extinguisher in May of 2020. And the cases abound. The UN Secretary General called for a ceasefire behind the closed doors of our homes. I have only heard ceasefire in the context of bombs and guns, like we sadly see in Ukraine today. And just as Dr. Moeti said, ILO tells us that over 100 million women health workers were working relentlessly and still do in hospitals and at home, in care homes, 70% of them being female. And also the fact that there's a UNDP and UN Women study that says women on the average made up only 24% of COVID-19 task forces. And at the time of that study, only 26 task forces shockingly had no women at all. So we had victims locked down, locked in with their abusers. There was reduced access by human rights defenders like ourselves, working on issues like harmful practices against widows, early marriage, female genital mutilation, which, by the way, increased with school closures. We've heard of the disruption of economic opportunities. And thank you, Dr. Ntumi, for mentioning mental health, because there was reduced psychosocial support. You and I know the importance of the touchy-feely aspects of addressing mental health as different to addressing it remotely or virtually. And of course, there was decreased access to vital sexual and reproductive health services. So we had decreased access to crisis centers. We heard of how a country like France, for example, converted hotels to shelters. And this was something that was predictable and preventable. But in the state of preparedness, it was not part of most of the initial COVID-19 response. And it has been alluded to already, lack of diagnostics equity. In a meeting last week in Ports to Arms, we heard a lot about how, because there's lack of diagnostics equity, more men were diagnosed. And therefore we need gender-based approaches to pandemic preparedness. Why was it that, the pregnant women were left behind in the vaccines? Why is it that, we had issues around media bias in some cases? And we must ensure that it is part of all conversations as we are having today. One of the recommendations is a global treaty to end all forms of violence against women and girls. Because even though at the law, is only as good as its implementation. We start with the law, we train responders, we ensure that there are adequate services. We need to ensure there's prevention education and dedicated funding to address violence against women and girls. Thank you very much.
Thank you very much, Dr. Mwadinobi. So many lessons learned and a lot of challenges for women in this COVID-19 pandemic. So now that you have heard from our panelists, it is your time, journalists, to ask your question. To do this, please use the Q&A function on the Zoom platform. Tell us your name, the name of the media organization you represent to have your question asked. And if you would like to go live, you can raise your hand as well as indicate to them in the chat that you would like to go live. We also have on hand to answer your questions, Dr. Adelaide Onyango, who is the director of the Universal Health Coverage Healthier Population Cluster, Dr. Richard Mihigo, the coordinator for immunization and vaccine development, Dr. Tiano Balde, the incident manager for the COVID-19 response, and Dr. Leopold Widrago, who is the regional advisor for sexual and reproductive health, all at the WHO Regional Office for Africa. So right now we have Daniel. You can take your question live, please.
Okay, thank you very much. This is Daniel Arab-Moy from CGTN Africa. My question goes to Dr. Moeti. Dr. Moeti, March 11 marks 2 years since the World Health Organization declared COVID-19 a global pandemic. How is the COVID-19 situation in Africa, and how has the continent handled the pandemic?
Okay. Thank you very much, Daniel, for your question. As I said, we have come through a fourth wave, a very high peak fourth wave of COVID-19 in Africa. And we are seeing cases going down in most countries. We have only a small number of countries, mainly in North Africa and South Africa, where there's a significant number of cases, but it's all generally in a downward trend. I would say that the third peak was the most lethal in terms of mortality. And the fourth peak was very high, driven by the Omicron variant, where there was a large number of cases, a very dramatic increase. But the death rate has not been as severe. And we are seeing, for example, the number of deaths progressively decreasing. In the past week, we've seen reported 1,500 or so deaths, as opposed to 2,840 almost the week before. So we are seeing a decrease in the number of deaths. We've seen African countries really, from a very low beginning, ramp up their response to all aspects of the pandemic, starting with testing, being able to track, have data to see what was happening as far as transmission was concerned, and then latterly increase their capacity to provide case management, to treat, manage the illness among people who were affected. We have to acknowledge that in the third wave, we saw a very severe reflection of gaps in particularly intensive care, access to oxygen supplies with the types of death rates that we saw in Africa. But in the last wave, countries had ramped up with support from WHO, the African Union, other partners, their capacity to provide care for COVID-19, which we anticipate is going to be taken into the future as far as expanded access to this type of services is concerned. And then, of course, we've seen the response in vaccinating populations, starting with the most vulnerable groups, the elderly, and going to expanding to other population subgroups. We have at the moment overall about 13% coverage in Africa with the vaccine, with second dose or complete vaccination of the population. we know that Africa has been left quite significantly behind other parts of the world as far as vaccination is concerned. And there's a great deal of work going on now by the governments with support from WHO, other UN partners and others to ramp up the capacity to deliver vaccines and also to improve the vaccine demand in the population in Africa. So I would say it's been a very challenging 2 years for African governments and people and their partners in this pandemic. We have lived through 4 waves. The 4th wave was dramatic in its scale, luckily not so lethal in terms of the mortality. It is coming down now. And what's most important is for us to anticipate what's going to happen next. We know that when it starts to get cold in countries, it was the case in North Africa, this is coming now in Southern Africa, people start to stay indoors, keeping a distance is difficult. So we need to be now preparing based on the experience of 4 waves for what we have seen in the past, including, of course, ramping up significantly vaccination so we don't get severe illness and death.
Thank you, Dr. Moeti. Dr. Balde, do you have anything to add on this question?
Yes, Dr. Mary, thank you very much for the opportunity. I think Dr. Moeti has said it all. I think the other point that we might need also just to take into consideration is the increasing capacities in terms of clinical case management. I mean, anticipating really all of these type of, worst case scenario that we might, but that we might also, be prepared for. So I think overall, I think Africa went through these 4 waves. With some kind of at least, efforts and also with a good result, I will say, because we know that, the level of mortality, reduces, from one wave to another. And also we saw also even the level of the infection, even though we know that the Omicron, came with a lot of more other infections. But overall, I would say that the COVID now, we are looking for trying to control it in the region here as well as globally with all of these different mechanisms that we are currently implementing in interventions. Thank you, Mary.
Thank you, Dr. Balde. The next question is coming from Yusuf Ba from Al Jazeera. The question is coming to Dr. Moeti, and Dr. Richard Mihigo could weigh in. What are the COVID consequences of the Russian invasion of Ukraine? What do you expect as most of the people are not fully vaccinated?
Yes, thank you for that question. Well, first of all, I'd like to echo the words of the UN Secretary General, that this escalating violence, which is resulting in civilians being killed, including children, is really not acceptable. And it's very important that civilians must be protected. So I'd like to express our compassion and empathy for all the people that have been impacted by this military offensive. And we know that there are reports not only of Ukrainian people and other people from other parts of the world, but the African students and migrants who are being affected by the situation, who are trying to escape and who need support. And we hope that their needs will be met. So for the moment, we have no information really on the impact that this military offensive will have on global vaccine supply or delivery, or indeed the response to COVID-19. And we anticipate that as we learn more about the situation, the potential impact, for example, on transportation at the global level, we're not sure that this will have an impact on the supplies that are needed to respond to the pandemic around the world, and particularly in Africa. We are aware that certain medical equipment like PPE gear for health workers remain in short supply on the continent, and we hope that this will not be exacerbated if this military offensive continues or even expands. We are aware, for example, that some exports from Russia to some of our countries, some food items, wheat, for example, is likely to be in short supply now that flights have been stopped from that country. And we hope that this will not. We fear that this might cause then prices of food to start to go up in some countries, exacerbating an already difficult situation for some families in some of our countries. But this is a situation that we'll continue to monitor in terms of its impact on particularly the response to the pandemic, other supplies that are needed for health. And we hope that it will not be significant.
Thank you, Dr. Moeti. Dr. Mihigo, do you want to weigh in on this question?
Yeah, thank you, Dr. Mary. I think just to complement what Dr. Moeti eloquently addressed, I think that when we looked at the vaccine supply specifically, I think we believe that in the short term, there will be very little impact on the vaccine supply and updates overall in the region. When we looked at the close to 700 million doses that of vaccine that have been received on the African region, when we looked at the vaccine that is produced in Russia, the Sputnik V, I think close to 3.5 million doses only have been received in Africa. This represents less than 0.5% of all the doses that we have received. So, but we need to look at the mid to long-term impact of this military offensive, and particularly the economic sanction that are going along with that. And it's very difficult to say on the long term how this will evolve. But again, the situation is changing every day, and WHO and the partners are really adjusting to the situation. So we will be monitoring very closely on that. As you know, the COVAX initiative has changed a bit the supply process, where we are moving now towards a more demand-driven pipeline, where the needs of the country have been expressed. And so far, we have quite a very let's say, very rich vaccine pipeline in the midterm. Over.
Thank you, Dr. Mihigo. The next question is coming from Columbus, from Voice of America, and it's coming to you, Dr. Ntumi. How has COVID-19 affected gender equality on the continent, and what can we do to address this? Dr. Ntumi, please.
Ok, merci pour la question. Alors, comment la COVID-19 a affecté les femmes? Mais comme cela a été mentionné par Dr. Moeti et Dr. Noadi Nobi, les femmes en Afrique sont celles qui soignent. Donc, elles ont été beaucoup plus exposées à l'infection, mais avec aussi avec peu de protection, la mise à disposition des masques et évidemment les mesures barrières n'étant pas respectées, puisqu'en Afrique, ce sont généralement les gardes-malades. Ensuite, les femmes ont été très affectées parce que les femmes sont en Afrique, travaillent beaucoup dans le secteur informel. Donc, où il y a le secteur informel est composé d'environ 70% de femmes. Et dans ces femmes, la plupart sont des cultivatrices, donc travaillent dans le milieu agricole. Et donc, l'impact a été immédiat, puisque quand on a eu le confinement, les femmes ne pouvaient plus aller au champ et donc ne pouvaient plus vendre leurs produits. Il y avait un impact aussi, évidemment, dans les marchés locaux, puisqu'elles ne pouvaient plus vendre. Donc, elles ont été frappées de plein fouet. Il y a eu une baisse, je pense, de 60% des revenus du secteur informel avec cette pandémie. Donc, déjà là, ça a été un choc sur les femmes. Ensuite, ma collègue, Dr. Noadi Nobi, peut mieux expliquer l'impact sur les femmes en ce qui concerne les violences domestiques, les violences sexuelles. Et puis j'oubliais un point aussi où les femmes ont été très impactées, dans la perte d'emploi. Puisque les personnels peu qualifiés, ont été celles qui ont été très rapidement renvoyées parce que les entreprises ne pouvaient pas fonctionner, donc elles ont aussi été largement impactées pour celles qui n'étaient pas dans le secteur informel par la perte d'emploi. Voilà, donc évidemment, cela veut dire qu'il faudrait des mesures, maintenant des mesures fortes pour soutenir toutes ces femmes-là, avec celles qui sont dans les microcrédits, avec de la formation pour qu'elles apprennent ce que c'est que le e-commerce, pour pouvoir, pour la prochaine pandémie, pouvoir écouler les produits. Donc il y a beaucoup et puis mettre en place des mesures, des cellules d'écoute, d'aide aux femmes par rapport à cette grande violence qu'elles ont subie. Voilà. Donc, il y a beaucoup de mesures correctives à mettre en place. Merci. Over.
Thank you, Dr. Ntumi. Dr. Wadinobi, do you want to weigh in on this question?
Yes, most certainly. Just to, reinforce the importance of preparedness. And, previous speakers have spoken about, our level of anticipation. In fact, to go back to the question regarding the current conflict between Russia and Ukraine, to reinforce the fact that, we join the world in suing for peace and a cessation of, attacks, especially on the vulnerable civilians. But to say that part of the preparedness should be that expectation that every response should be gendered. How are we preparing specifically for men as opposed to women? How are we preparing for people living with disabilities? COVID-19, for example, on account of the skewed gender diagnosis for men, meant also that we have seen spikes in the numbers of deaths for men. And that has created a new cohort of widows. On the Africa continent, we still have issues around harmful practices against widows. And in the context of COVID-19, there has been reduced access, as I said before, by human rights defenders who would normally go out to defend those who are undergoing one form of harmful practice or the other. So we cannot emphasize enough that it should be anticipated. Our state of preparedness should be such that our response is gendered. If task forces are being set up, let us ensure that it is inclusive of men, of women, of people living with disabilities, so that when we talk about nothing for us without us, that those who are put in in either task teams or task forces are actually those who can speak to the situation because they have undergone the situation. They can bring those nuances into the response. No longer should we say that we were not prepared for increased violence against women and girls when we know that it already exists and it is 100% preventable. Thank you, and over.
Thank you, Dr. Wadinobi. Dr. Moeti, do you want to weigh in on this gender equality issue?
Yes. Yes, I would just like to add that, of course, I think it's already been said by my fellow panelists, women play multifaceted roles of caregiving, both in the healthcare system and in families. And one of the main aspects of the lockdowns during the COVID-19 has been the closure of schools, meaning then that mothers who were struggling to continue to earn a living for their families, as Professor Francine has so eloquently described, then also had to deal with caring for children who were at home, trying to learn from home under very challenging circumstances indeed. So we know very well that women's caregiving role across the board, which is largely unremunerated, as we know very well, meaning when a woman wakes up, she's at work at home, then she goes to actual work and she comes back, continues to work at home. This was very much exacerbated by the fact that even the child care and making sure that the children are learning, making sure that food is being cooked for them, largely fell on the shoulders of the women. So it's been a huge burden, not only a physical burden in all the work that women have had to do both at home and in trying to sustain the earnings of their families, but also a psychological burden of having to juggle these roles at home. So all of this, I agree very, very strongly with Prof. Nwadinubi. We need to much more explicitly incorporate gender inequity, gender-related aspects into all the work that we are doing, including on preparedness and response to crises of this nature, so that it becomes part of the process to deal with the anticipated effects.
Thank you, Dr. Moeti. And the next question is from Henry Williams from IN247. This question is coming to you, Dr. Richard Mihigo. At the current rate of vaccination, when is Africa expected to reach 70% of its population?
Yeah, thank you very much. This is a very difficult question, but I think we have seen the last couple of weeks a very accelerated pace in terms of vaccine delivery in the region. We need to recall that the majority of the country in Africa are lagging behind that important milestone. But there has been at least some very positive development. The first one being that the supply constraints that have really hampered the delivery of vaccination the last year has been to some extent resolved. And for the first time, we have seen a situation where the supply now outstripping the demand. Secondly, I think we are now seeing an acceleration in the preparation and the ramping up of vaccination strategy in different countries. As we speak, for the moment, I'm, for instance, in Nigeria, where we are working with the national authority to see how we can accelerate the vaccination drive in this very important and big country in the region. So overall, what I can say is that the journey is going to be a little bit bumpy, but countries have put in place, I believe, the right strategy, not only on the supply side, but I think most importantly, on the demand side, to try to remove all the different bottlenecks that have been in place. And we are starting to see really a very positive sign coming to the country. So we are carefully monitoring this situation in all the region. And we believe that we have a very important window of opportunity that we need absolutely to seize for the moment and accelerate the pace for vaccination.
Thank you, Dr. Richard. The next question is from Sarah, The Guardian UK. This question is coming to you, Dr. Adelaide. Obesity is rising fastest in low and middle income countries. According to the new report by the World Obesity Federation, almost a quarter, 22% of preventable deaths from non-communicable diseases are in Africa, and they are attributed to high BMI. As the region is experiencing one of the biggest rise in BMI, the impact will worsen over the coming years. In addition, the region faces challenges associated with double burden of malnutrition. Health systems in the region are already ill-equipped, said the report, and should not be further overstretched. So she would like to have your comment on this report. Over to you, Dr. Adelaide.
Thank you very much. An important question, because yes, we recognize that the drivers of undernutrition are still very much a challenge for us for the African region. And at the same time, we have changing food systems and lifestyle patterns that are driving the consumption of the unhealthy types of food, these ones that contain lots of sugar, salt, and as Dr. Moeti has mentioned, the wrong kinds of fat, the trans fats and the saturated fats. These are drivers of NCDs. And we're looking therefore at a situation where we are escalating the increase in NCDs in a region that already the health systems can hardly handle the infectious diseases that are much easier to treat than the NCDs that are longer term and very, very costly for the public health systems, as well as for families, because we do not have health insurance. So it's critically important that we address these challenges. And we are working already with many governments that realize that there is a problem here, a costly problem for the economies in this region. And many of them have joined ranks to be front-runner countries in coalitions for the prevention of obesity and for the promotion of food systems that will increase the supply of healthier options in a more affordable range of prices for the poorest people. Because right now, it's cheaper to buy a can of sugar-sweetened beverages than an equal quantity of freshly squeezed orange juice, for example. So it's important that the food systems are regulated, and this regulation is a responsibility of governments, which at this point we're still really not there, because there are many challenges facing. How do you regulate when these are the companies that they claim that they are offering employment for the populations? The governments need to balance that, but I think we also are going to have to play our part to explain that it is important to invest, looking at the long-term positive outcomes, invest in those regulations, even if initially we're going to look like we are slowing down the investments. They have to be investments that also respect public organization that needs to they really need to take this seriously, because it is costly for us not to regulate the consumption of these unhealthy things, but it needs to be then taken down to the ground, and WHO is offering all the things.
Thank you very much, Dr. Adelaide. Paul, are you ready to take your question live?
Yes, thank you very much. So my question goes to Dr. Moeti, and if Dr. Miigo can also contribute. It has to do with, you recently mentioned that vaccine supply has really increased on the continent. But while looking at data in some African countries, a case in reference on Nigeria, I'm seeing that we have some states where we've had more than 2 million individuals that came to receive the first dose, but less than 1 million came for the second dose. I don't know what is being done, what is the rationale behind more people collecting first dose, but very few individuals coming for the second dose. And I don't know if this is a major concern for the WHO, and how is this issue being addressed? Thank you very much.
Yes, it is a concern, and it just points to the need to work very hard to reach out to people so that they understand the benefit of a second dose, and even a booster dose is being promoted and is being provided in the countries that have had the supplies. We believe that what actually happened with the Omicron virus variant of the virus, where there were many infections and there was a kind of alarm, but not the same impact in terms of severe illness, making people aware that this is a potentially lethal illness, has created a certain level of complacency, we might say. People feel you might get infected, but you may not get very ill. It simply points to the need to have people understand the importance of completing the vaccination and the fact that as time goes on, there may be a need for further vaccination as the immunity wanes with time. The strategy now is very much around creating the demand, reaching out to people, using different types of approaches. Initially, the campaigns or the services were fairly static and people were being told, come to this site, come to this clinic to be vaccinated. We've recognized the fact that the vaccines have to get out there to where people are, where people congregate, in markets, in workplaces, in churches, and out into the community. And as well, we recognize that we need to encourage countries to obtain the type of vaccine that is most appropriate for the context. So if we're going to go out to rural areas where the use of doses, vials might be less efficient, if we are using certain types of vaccines where the demand of the cold chain might be more efficient, it might just be as well to use the kind of one-dose vaccine that's not so demanding in the conditions that it demands. And then most importantly, get the vaccine out there, really get down to the community level and help people understand why it's important to come to be vaccinated. And this is something that we might need to live with into the future, because we cannot predict that we're going to put an end to this pandemic and it'll be back to life as we knew it before. We think that this is something that will need to continue, and people need to understand their part in coming to be vaccinated and supporting others to be vaccinated.
Thank you, Dr. Moeti. Dr. Mihigo, do you want to weigh?
Yeah, thank you, Mary. No, I think just to take on, to add a few things on what Dr. Moeti said, Paul, I think the issue indeed has been largely discussed here in Nigeria, where I'm currently on mission. I think, and it's not specific to Nigeria, I think it's across the country, as Dr. Moeti said. I think how to make sure that we are increasing really the demand, particularly during this period where the risk perception is becoming very low after this Omicron wave. Secondly, I think to be even a bit more specific on Nigeria, Paul, I think we have seen that last week, working with the partners, the government have launched what they call the Scales 2.0 strategy, which has at the core of its principle to really decentralize the delivery of vaccination to the states and the LGA level, to make sure that the planning process is really from bottom up, so that the LGA, the communities are very well involved in the planning process, and the increase of sensitization and the demand to make sure that we are breaking or narrowing the gap between those who have taken the first dose and those who are expected to receive the second dose. So it is on playing on and acting on all of these different areas, on demand, on explaining the needs to continue to put a focus on vaccination. We don't know what is coming down the line. And I think that we should really, again, as I said before, seize this opportunity where we have a low, let's say, incidence of the disease, to increase the vaccination coverage, particularly for the groups that are more vulnerable, healthcare workers, elderly, women. And I think Professor Ntumi, in her opening remarks, made a very important point around pregnant women who are not vaccinated, for instance. And we saw it here in the field. I think exposing them even more to mortality and a severe outcome for the disease. So probably this is the time where we need to increase that approach to make sure that those who are more vulnerable are really reached.
Thank you very much, Dr. Mihigo. So this next question is from Abigail Tembo from Zimbabwe Broadcasting. And the question is coming to you, Dr. Leopold. Which countries have the highest incidences of maternal deaths, and what were the causes of these deaths? Over to you, Dr. Leopold. Please unmute your microphone. Yes, go ahead.
Okay, thank you for this important question regarding maternal mortality. We all know that maternal mortality is a kind of silent tragedy, which is affecting, in particular, the African region. And we know also that this is also and health system issue. What is important? This I think 66% of all, and most of countries in Africa still have a high maternal mortality ratio, and the country with the highest maternal mortality ratio in Africa are Sierra Leone, Central African Republic, Chad, Nigeria, South Sudan, Liberia, followed by Burundi, the Gambia, Democratic Republic of the Congo, Guinea, Cote d'Ivoire, Malawi, Mauritania. All those countries are still reporting more than 600 maternal deaths per 100,000 live births. This is very, very high. And the main causes are related to severe bleeding, most after childbirth, what we call the postpartum hemorrhage, followed by the high blood pressure during pregnancy and during childbirth, preeclampsia and eclampsia, followed by infections, usually after childbirth, and also unsafe abortion. Unsafe abortion, what is really representing an increasing cause of maternal death in our region. And we know also that sometimes underreported in our countries. Thank you, and over.
Thank you, Dr. Leopold. Prof. Ntumi, do you want to weigh in on this issue of maternal deaths?
No. I think she gave the answer. No, I have nothing to add to that.
Okay, so we are going to take the next question. It's coming from George from Reuters News. This question is coming to you, Dr. Moeti. Is the WHO worried that the world's gaze has turned to Ukraine and it may mean the general public is less focused on COVID-19? Will this lower the rate of vaccinations?
Okay, thank you. That's an important question. I mean, for the moment, and as we said before, we are, of course, particularly concerned about the situation locally and in the surrounding countries. In the Ukraine, our colleagues in WHO in Europe are working very hard with partners to make sure that the humanitarian response is scaled up for those people within the country and also for those who are in the neighboring countries outside, including people from our region. What we have observed is that, of course, this is the issue of the day. It's absorbing a lot of energy at the international level as various parties try to mount a response and try to influence what's going on in the country. We are aware that countries are going to try to balance their attention. What's happening in Ukraine is very tragic. It's a big concern. At the same time, there is need to continue with the work that is at hand to deal with the pandemic. We hope very much that what will happen on global markets, transport situations, the transport of some of the tools that are needed is not going to have an impact on vaccines, other tools being moved around and the attention being paid to vaccination. And we simply will have to work on all fronts, on supporting the response in Ukraine and surrounding countries, and also on continuing the very important work on this pandemic. Certainly, the financing, I was very glad to hear the announcement, for example, by the German government of their contribution to the ACT accelerator of $1 billion more for the work that's going to be done. Germany is a European country that's involved in the discussions about the Ukraine, and we hope that we can sustain the attention on the pandemic and as well as act globally to respond to this crisis in the Ukraine. Certainly, we are embarking with our partners on a very intense support campaign to the countries that are lagging the most behind in rolling out the vaccination. We're sending people into these countries, and that work must continue even as we address this very tragic crisis that's in Ukraine.
Thank you, Dr. Moeti. And the second part of Rita's question is coming to Dr. Richard Mihigo. Will the WHO revise its target of vaccinating 70% of the world population by mid-year?
No, I think the 70% vaccination coverage target, it's a very important global benchmark that we are all aspiring to, because of that is something that will help at least putting all the countries at the same level of vaccine distribution, uptake, and towards the global equity that we are calling for so long. Now, how in the African region we are taking this forward, I think we maintain that remain an important benchmark. But in the meantime, we are working with individual countries to help them set their national vaccination targets. I think that is very important, because part of this is to make sure that in a particular country, starting by the more vulnerable priority groups, are really reached as a matter of priority. And of course, based on the demographic profile of some countries, I think some country may reach that level of protection of all the individual and priority groups without necessarily reaching the 70% per se vaccination coverage. But I think what is important at this stage is to make sure that, number one, we are striving all to reach that very important benchmark, but at the same time, country really try to customize that coverage targets by their ground reality, by their demographic profile, making sure that all of these priority groups, starting by the more vulnerable, are reached at a very, for instance, maximum level.
Thank you, Dr. Richard. And then our last question is to you, Dr. Balde. This question is coming from The Guardian in Nigeria. Is Africa out of the woods with COVID-19?
Thank you, Mary. And I think it's a difficult question to answer. I'm seeing Dr. Moeti shaking the head. And so I think it's quite very important to note that really we are still into this pandemic, and we are still really seeing, much of the cases, a lot of infection and some of the deaths. And it's important also to mention that, given the fact that many countries are somehow, change some of their approaches. We are not really probably seeing the true reality of the situation in the pandemic. The level of tests has somehow decreased, not only here in Africa, but in almost globally. So the figures that we are having probably might be an underestimate, of the real situation. So we are still into this pandemic, and especially in our region here, given the limited low level of vaccination, I think it's really important that we keep continuing, monitoring the situation and being especially ready for responding to the next potential wave which can affect our region. And doing that is really to be to have all of the materials and equipments, for being able to provide the necessary medical, care to the people who will be affected by the COVID-19, but also all of the other measures. So I think we really need to continue being focused to try to control, definitely the pandemic in our region based on our context here, based on our realities, and based on the resources that we have. So that's what I can say at the moment. moment. Thank you, and back to you, Mary.
Thank you, Dr. Balde. We are now coming to the end of this briefing for today. And so we will turn back to our panelists to give us their last thoughts. And as you give your last thoughts, there was a question that Linnea from For You Media wanted you to touch on. How can women help to curb the spread of COVID-19 in your last messages? So let me start with Professor Ntumi, then Dr. Nwadinobi, and then Dr. Moeti.
Ouf, c'est dur d'être la première à commencer. Last word. Le mois de mars, on va parler du mois de mars, qui est le mois de la femme. Je dirais que ce qu'a dit le dernier speaker, à savoir qu'il faut garder la vigilance. Les mécanismes qui ont été mis en place doivent continuer d'être renforcés. Et effectivement, ma crainte, c'est qu'on oublie la Covid avec la guerre en Ukraine, mais la Covid est toujours là, il faut qu'on continue d'en parler et rester sur le front. Les femmes ont toujours été sur le front, mais là, il faut qu'elles soient de plus en plus soutenues, que ce soit dans la recherche, que ce soit dans les hôpitaux, voilà, à tous les niveaux, il faut qu'on apprécie sa contribution, mais que surtout, elle soit mieux soutenue. Et puis, je voulais juste rebondir, elle est peu représentée dans les comités de riposte. Il faudrait qu'on prenne vraiment la pleine mesure de l'importance et de la spécificité de la femme. Voilà. Over. Merci.
Thank you. Dr. Nwadinobi?
Yes, my parting words would be, let's be prepared. Let's anticipate with the data and knowledge that we have. It's a dynamic situation, but let's use the data that we have to be better prepared. Speaking from the medical women's constituency and knowing that women in healthcare constitute over 70% of the workforce, let's spare a thought for our heroic healthcare workers. Lastly, to say that whatever we do, it should be inclusive. Nobody wants to be left behind. And to answer the specific question of how women can help, look to how women have coped over the years, study carefully the coping strategies of women. Some talk of resetting the button, some talk of a new normal. Well, it's quite simple. Look to how women have done it. As Dr. Moeti said so eloquently, unpaid care work, we have, multitasked. And there are those who have noticed, especially in working from home, how incredible this unpaid work in the home has been. So let's go back to looking to how the women have done it in their homes, in their communities, in informal spaces, and bring more women to the formal spaces. Thank you very much.
Thank you very much, Dr. Nwadinobi. And finally to you, Dr. Moeti.
Yes, thank you very much. First, I'd like to really thank my fellow panelists for having joined us and for your rich contribution to our conversation today. It's been great. And then secondly, I'd like to say, first we need to thank women for what they've already done in the response to the pandemic. Their contribution, often unrecognized, definitely very often unremunerated, has been amazing at all levels, at the community level, in trying to deal with the economic impact. And of course, in the healthcare space, women are very much also teachers, especially teachers of younger children in our education system. So they've played really a multifaceted role, which quite often goes unrecognized. So I think the responsibility then is for all of us to make sure that as we go forward, we learn from this realization and we do our utmost to ensure that gender aspects are incorporated into every component of a response to a pandemic, including in preparedness. We've seen, and we are learning these lessons again and again. In an Ebola outbreak, we see certain things happening. In this pandemic, which has had such a devastating economic impact, which will continue years into the future, with women being worst affected, we know we need to anticipate then. As our countries develop social support, social safety nets, they need to have a gender aspect as well because of the special role that women play. And we know that when women are earning better, what they earn goes back into the family. It benefits other people in the family much more than the earnings of males. This is documented. There's data to show us this. And then finally, let's anticipate. I agree very much with Dr. Eleanor, let's anticipate based on previous experience what's going to happen. There will no doubt be other waves. Our coverage levels with vaccines can only help to prevent severe illness and deaths, we hope. So let's anticipate, let's look with a more gendered eye at what these responses should be for the next wave. At least that's something we'll have learned from this International Women's Day, which is coming next week, about the role of women. So again, thank you very much for having joined us, my fellow panelists, my colleagues in WHO, and to the journalists who have joined us today.
Thank you very much, Dr. Moeti. We have come to the end of the briefing for today. Thanks, everyone. Thanks, excellent panelists, the journalists, everyone, experts. We sincerely appreciate you, and I wish you happy International Women's Day in advance. Thank you, and have a good day.